it takes a bit.
All right. Well, good afternoon or good morning, everyone. It's great to see some familiar names and faces. Let a few people get settled in virtually here. I see a few are still getting connected to audio. Let's give them a chance to do that. I have Parker Laney is here. He will be assisting initially with just getting us started off technically on the right foot, making sure that I don't break anything on Zoom, which I've been known to do from time to time. So hopefully we'll get through that piece without any big issues. So, but Parker's here. He's a colleague of mine, and he'll help us get started. If you are having trouble with your audio settings or having trouble getting connected, reach out to him via chat, and he can try and troubleshoot with you. But we're thrilled to have so many of you here this morning. I know I was telling Parker before we came on, this is kind of a tough time to schedule events and do webinars and trainings because a lot of folks are still, out of the office or engaged with family activities. So we really do appreciate you registering for this and joining us this morning for this another installment of our ESAS series, which is the acronym is Essential Substance Abuse Skills Training. This really, as many of you know, this webinar series is designed for those of you working in the behavioral health field, either new to the field, or perhaps you've been working for a while, maybe working towards a credential, or you're just, need a refresher or some updated information. We are going to offer CEUs for this, so it's really important if you want CEUs. We're going to reach out to you post-event. I'll talk about this in a little more detail, but we're going to reach out to you post-event via email. You must reply to that email and request CEUs through that platform in order to be eligible to receive those. And then just be patient with us on getting those back to you. We are a small staff here and rely on our students to help us with getting those CEUs out. So great to see everybody. I've got some really important information we're going to go over today. I'm sure that many of you are already engaged in direct services and are already doing much of the things that we're going to talk about today. But I'm going to let Parker get us started and get me introduced and go through a couple of orders of business, and then we'll go from there. So welcome everybody.
All right, well, like Steve just said, we're all gathered here for the ESAS Referral Service Coordination Documentation session today. Thank you everyone for joining. Before we get started though, we always like to inform you that the ATTC here is part of a much larger nationally based center. So you can see on this map all the other areas that are serviced. And then we also have a disclaimer that the National American Indian Alaska Native Addiction Technology Transfer Center is supported by a grant from SAMHSA, the Substance Abuse and Mental Health Services Administration. The content of this event is the creation of the presenters, and the opinions expressed do not necessarily reflect the views or policies of SAMHSA, HHS, or the American Indian Alaska Native, ATTC. And immediately after and during today's presentation, there will be a follow-up email sent after, but towards the end, we're also going to drop a link in the chat that is a link to our evaluation survey. We really appreciate when these are filled out so we know what to change and what to add for our next sessions. And we just really appreciate if you guys fill that out. And we always like to, before we start our sessions, go over a land acknowledgement and take this time to acknowledge the land and pay respect to the indigenous nations whose homelands were forcibly taken over and inhabited. And past and present, we want to honor the land itself and the people who stewarded it throughout the generations. This calls us to commit forever to learn how to be better stewards of these lands through action, advocacy, support, and education. We acknowledge the painful history of genocide and forced occupation among the Native American territories, and we respect the many diverse indigenous people connected to this land on which we gather from time immemorial. While injustices are still being committed against indigenous people on Turtle Island, today we say thank you to those that stand with indigenous peoples and acknowledge that land reparations must be made to allow healing for indigenous people and to the Mother Earth herself. And then introducing today's speaker, Stephen G. Steiny. He is the project manager for the National American Indian Alaska Native ATTC, and I'll let him introduce himself a little bit more.
Thank you so much, Parker. And just wanted to note that that land acknowledgement was drafted by 3 former members of our team from the Meskwaki and Winnebago nations, respectively. So we just want to acknowledge that. Good morning, everybody. As Parker mentioned, my name is Steve Steiny. I'm one of the department managers here. I oversee the addictions portion of our American Indian Alaska Native ATTC. And I have a clinical background. As many of you know, I've shared this before, but I've worked in a clinical setting, behavioral health, addiction setting for many years. And recently, it'll be 4 years here in a couple of weeks, came on here at the University of Iowa and started working at the center. So I have a lot of clinical experience, but have shifted more to teaching and research and trying to connect and assist as many tribes as we can connect with around the country, and have been doing that for the last 4 years. Connect with them, work with them, collaborate with them on behavioral health issues related to substance use disorders and mental health disorders and other co-occurring or comorbid issues. So I'm not Native, but I have had access to absolutely brilliant team of Native consultants and advisory council members who have really helped me better understand Native culture and Native ways. So today we're really going to talk more about this is more of a Western approach to referrals and documentation and service coordination. But I want you to, if you are working with Native patients or are Native and working with Native patients in a tribal setting, please feel free to add chats in the comment, or feel free, hopefully we'll have some time at the end to do some Q&A, but I want you to really sort of think about the cultural implications of some of this information and how it applies to the patients you're working with, if you are working in for a tribal agency. So just wanted to say that, put that out there. Great to see some familiar names and faces, and I'm really hoping 2023 is going to be a great year for everyone. So let's go ahead and Parker, if you can give me permission to share, I'm going to pull up the main slide deck today. Just as many of you know, I am a person of long-term recovery. That has had an influence on the work that I've done in the past in the clinical setting, and continues to influence the work that I do today. So let's see if I can share my screen and get the main slide deck up without breaking anything. And because Parker knows I've been known to break Zoom from time to time. I'll just go ahead and admit that right now. Let's see, I'm going to get that slide deck up, and yes, that is the slide deck we're looking for. Great. Okay, so far so good, everyone. I know we're getting some different weather-related issues around the country. We had a little bit of an ice storm this morning, so I was trying to figure out whether I could make it to my actual office here on campus, or if I was going to have to do this from home. So, but I made it. Was able to make it here to be with all of you today here at the College of Public Health. So let's see, Parker, I'm going to try and get this into presentation mode. How does that look for everyone? Can you guys see a full screen there?
Perfect.
Oh, look at this.
Yes.
2023 is off to a great start, ladies and gentlemen. We are going here. So again, much of the information we're going to go over today, those of you that are working in the field, those of you that have an active caseload and are doing this work, this really important work, will be able to identify and understand much of what we talk about. So some of this may be a refresher or an overview for you, but think about the cultural implications. And also, those of you new to the field who are getting ready to credential or enter the field, this is a great sort of stepping off point and really a good foundational piece for you to build on. So happy to have you all here. This is sort of the last segment of what we've been talking about leading up to this the last 3 months. We've talked about treatment planning, we've talked about assessment and screening and how they're all interrelated, and we continue to assess and access that information as we work with our patients or our relatives in that clinical setting. So this is sort of the last piece of this, and then we're going to reset next month and go back to kind of restarting and go through some basic counseling foundations. But this is a really important piece. We're going to talk about referral, coordinating services, and I know it's the D word, documentation. It's part of the work that we do, and even though sometimes it can be cumbersome, it's really important that we acknowledge this as part of the expectations in our field. So just to give you kind of an idea of what we hope to cover today, and my slide deck is not real big today, so I'm hoping we'll have a little time at the end to have a dialogue or address some questions that may pop up in the chat. Feel free to use that chat. I would just ask that you try and stay muted during the presentation portion of this, but I will glance at that chat as we go and see if I can stop and address questions as we go. Use the hand raise feature too. That'll kind of help me know if there's a question out there as we're going along. Parker and I can kind of keep an eye on that as well. So there are our objectives for today. Let's jump right in. So again, I want you to think about this recovery sort of associated response. We're constantly looking at this treatment involvement as a process. It fluctuates depending on the patient's needs and situation, but it's a continuous process all the way through. And really, the bottom line, literally, is just really trying to collaborate with our patients and promote and advocate and really affirm their strengths and the goals that they have while they're involved and working with you. This is part of that rehabilitation process, or as was pointed out to me early on, sometimes it's a habilitation, where they may be learning things, life skills and coping mechanisms for the first time. So something important as well to keep in mind. This is kind of a visually, just to kind of get an idea as we talk about referrals and coordinating of services. This is just sort of I thought this was a good visual to kind of look at how this works. And you can see really at the center of all of this is this idea of a healing plan or a treatment plan, and how it branches out from this. And we've talked from the beginning about, from the very beginning of that assessment process, you're beginning to develop a treatment plan with that patient. And it builds, it's a living document. So out from this, you can see all of the connections to this sort of centerpiece. And we have, pharmacological intervention. We have the pharmacological therapy. We have behavioral health counseling. There's our intake and assessment, drug monitoring. We have self-help groups, and then further out, you have these. What I want you to think of these as sort of those referral spokes, or those pieces in the process that you may be making referrals to or working directly with or through and with the patient as you begin to make referrals along their treatment continuum. And we have continuing care also listed there. And this is important because we know that's, a really essential part of that post-primary care. Post-primary care really is where I believe recovery really begins to take hold and take place, because they're taking some of those early recovery issues and starting to apply them to different situations in their environment, whether it be family or work or the recovery environment itself, and connecting with peers and the recovery community. We know that substance use disorder treatment is most successful when the services are comprehensive and inclusive of issues specific to the individual. And, in the old days, those of you that maybe have been around a while, the old approach was to sort of treat one issue at a time. Well, we need to take care of the substance use before we can address this. Or really, the new model now is to really look at this holistically and to really simultaneously address these issues, to increase the chances of the patient having success throughout their treatment continuum. So that's just something to keep in mind. Comprehensive and effective treatment should really visually look like this. Now, in a perfect world, we know that there's going to be pieces that are missing and pieces that may not be realistic to include in this visual. But ideally, there should be, if you can imagine your patient's referral world, or their network, their network of referral or support services looking something like this. And that leads us to another component. Some of you may be familiar with the ROSC system of care, and again, this is something that can be, even if you're not calling it ROSC, there's still this idea of there being this sort of holistic, comprehensive sort of menu, if you will, of services and supports that can be worked together to meet the needs of the patient. One of the difficulties, there are challenges that we face in working with patients who have substance use disorders is, really trying to understand what some of those underlying issues are. And that's where it's not a one size fits all approach. It really needs to be looked at in this holistic manner. And so this, I think the ROSC system of care really addresses that well. It really covers all of the bases, and you can see out on the edges, you have this interconnectedness between recovery, wellness, and overall health, whether it be mental, physical, or physiological. So those of you that are familiar with ROSC are gonna understand this. If you're not familiar with it, maybe talk to a colleague or a coworker about this and see if they know anything. And there's a lot of information out there about ROSC too. So if you Google this or do a search on this, there's a lot of information about this system of care. So let's sort of look at what is referral, and we're going to go through some different components so that we have an understanding of what referral is, and it's probably one of the most essential components ethically to the job that we do, the work that we do, because if I'm working with a patient who has needs beyond my ability to treat, or it's outside of my scope or area of practice, it's really important that I have the capacity and the willingness and the understanding and the support to make referrals that are responsible and appropriate. That's one of the best, greatest gifts that I can give to a patient, is to make a responsible referral. We're going to talk about this. And again, many of you could probably cite examples where making the referral with or without the patient maybe being on board with it sometimes is absolutely essential. The more I can involve the patient in that referral process, the less anxiety they're going to have, and the more involved and the more sense of control and meaning they're going to attach to that referral process. But let's just look at this from a definitional standpoint. Referral is the process of facilitating the patient's utilization of available supports. These could be, clearly, obviously within the community, to meet the needs of that of some of the issues that were identified in that evaluation and or in that healing plan or that treatment plan. So again, we go back to this idea that the assessment that you may have done with this patient months earlier is still influencing and still having an impact on where you go post-primary care or what type of referrals you make. Seeking assistance for an issue or circumstances of a patient that is beyond the scope of the primary treatment facility. So again, referral is an essential part of the work that we do. This and I don't have to go over these verbatim, but just to give you an idea of how we establish and maintain and make responsible referrals, it really involves having this relationship with other components or other entities or services in your surrounding community. I can't tell you how important that was for my work to have a working professional relationship with other agencies that I could, in confidence and in good faith, make referrals to, that I knew that patient was going to be in good hands and they were going to get the care and support that they needed. Even if it was something as rudimentary as a dental appointment, something as basic as that, all the way to making a referral to a specific therapist or clinician to address a specific issue. There's the second point on referral is this idea of continually sort of assessing and evaluating referral sources to determine whether or not they're appropriate. And again, I can think of times in my own practice where I would call to make a referral and I would say, yes, I want to talk to Jim. I have a patient that we have consent signed and I really want to connect them with Jim. And they would say, well, Jim, doesn't work for our agency anymore. And sometimes that could be really unsettling. So it's important for me to know and sort of stay in the loop. But having those collaborative relationships with, key contacts, and if those change, to be able to update them. So I had kind of a running update list of referral sources and contacts that I would utilize when making specific referrals, and being able to communicate with them about evaluation and the patient's history, in an effective manner so they'll know what's going on, and only really giving that referral source the information that they need. They don't need the whole file, They may just need to know primary diagnosis, a brief case history, and treatment status or level of care status. Giving feedback to community resources regarding their service delivery. Again, if I would receive feedback from a patient that said, wow, I went over there to the place that you sent me and I sat in the waiting room for 20 minutes and no one said anything to me. I might call that referral source back and say, I had a patient that went over there and you guys weren't able to serve them. That might be something that I would consider not sending a patient back to that referral source. Sometimes we are limited in who we can send patients to. If we're in a smaller community or a rural setting, or even in an urban setting where there are lots of choices, it can be difficult to navigate that. Number 3, regarding what a referral is, differentiate between situations in which it is most appropriate for the patient to self-referral to a resource and instances requiring a counselor or a therapist referral. So again, if I'm going to suggest that a patient go and check out a self-help group, I don't need to make a referral to that self-help group to get them in. They can go and check that out themselves. Or they may say to me, I'd like to go check out this group. I want to go check out this talking circle that meets on Tuesday nights, and we would incorporate that into their referral and maybe into their treatment planning, and they would go on their own volition. There are other times where making a referral requires the approval or the formality of making that through the agency. So sometimes that's required. They may need clinical information, they may need diagnostic coding for billing purposes, and things of that nature. But things to keep in mind in this for this this aspect of referrals is understanding, assessment, and treatment planning. Really having a good understanding of the patient's readiness, sort of trying to meet the patient where they are, and this idea, this motivational interviewing idea of rolling with resistance versus forcing change. The example I could give, I go back to AA meetings, for example, or NA meetings. The clinic that I worked at early on mandated all patients to go to at least 2 AA meetings during their, I think it was during their intensive outpatient stay, which was a 4 to 6 week involvement for them typically. And they were mandated. They could not graduate or complete that IOP program unless they went to 2 AA meetings a week, I think it was, during their treatment stay. And I had opposition to that. Even though I utilized AA in my own recovery, I knew that that wasn't always a good fit for every patient. So we reevaluated that and did not make that a mandate. So if a patient is not ready for self-help, then mandating or forcing them into that can be it can be a really difficult situation. I'd be curious to hear what others think about that idea about forcing someone into, a service. We know that treatment is often mandated, but we're really talking about post-primary care here and referring patients out or connecting them with the resources, pro-recovery or pro-social resources in their community. And then lastly, the other bullet point on this is just making sure the patient is well informed about the referral process, so they understand why and when and how this how this works. I would often make referrals with the patient in my office, and we would make the call together and be on a speakerphone, and as long as we had releases, and but really involving them as much as I could with that process. Or we may talk later about that warm handoff. If there was a situation where I could walk the patient down to the continuing care group facilitator's office and introduce them and say, hey, this is John. He's going to be starting men's continuing care next week. I just wanted to introduce you to him, John. This is Jim. He's the facilitator. And what a great way to reduce some of that anxiety, in that referral process. It isn't always possible, but I think it's really important to keep the patient sort of informed and in the loop about the referrals, why you're making them, and get them involved in that process. Again, number 4 would just be arrange referrals to other professionals, agencies, community programs, or other appropriate resources. Again, this can be very time consuming for some of us, right? I mean, it can take up a lot of time, phone calls, emails, making sure we've got appropriate ROIs in place. There can be some legwork involved, but arranging those, coordinating those is really essential, and it's one of the greatest services we can provide to a patient, especially post-primary care services, because that's when, as I mentioned earlier, that's when the recovery really begins, is when that post-primary care ends. Again, building on point 3, explain in clear and very specific ways the why and the process, why the referral is being made, why it might be necessary to consider, and the process by which this takes place. I think it increases the likelihood of the patient following through if they see that there's some vested interest in their well-being and their early recovery, it can be absolutely essential to increase the chances of them buying into this and being part of this and really being proactive about it. A couple of other points, and again, I don't want to make this too complicated, but all of these components of the referral source are things to consider, and they're all connected somehow in this process. Um, I mentioned it earlier, but having, current information with the agency, having accurate information with that agency that you're making the referral with. Other agencies change. We know this. There's going to be changes in every agency, but trying to, as your role can be to try and be current with your referral resources. And then this can be a tough one, and I'll admit, being able to follow up or see if that referral came to fruition. If you've got a very large caseload, or have other duties as assigned going on in your clinical responsibilities, following up with every referral can be extremely challenging. So sometimes relying on support staff or having set follow-ups with a patient, even if it's a short phone call or email, just to see how the referral turned out, or even getting back to the referral source themselves to see if the patient has engaged. I know realistically that can sometimes be a challenge, just logistically and numbers wise. If you've got a large caseload, that can be a challenge. But it's something to keep in mind, especially if you know how important that referral was to the patient, to see if they've engaged and been able to get into that referral plan. Just a couple other things before we move on and talk about coordinating services regarding referrals. I know this is sort of related to 7, but following up, it is your responsibility. Sometimes that can be a challenge, and I can think of times where I may have followed up once, and then it kind of fell off my radar. So having a system or a mechanism, if you're still having a contact point with the patient, if they're still attending, let's say, a weekly continuing care group, or you're doing maybe monthly individual sessions with them, that's a great way to follow up with them. Or maybe they're continuing to come in for urine screening. You can ask them at that point of contact, hey, how did that referral source go with that couples therapy that we talked about? And they might say, oh, we went to a couple sessions, or no, I haven't followed up yet. It's important for you to do this if you have that opportunity, but I know it can be a challenge for a lot of people, a lot of folks. So yeah, no worries, Ben. I know somebody said they had to jump off, but I know people have other things going on. Lastly, just to check with the patient to see if they were able to engage in services. And I know I kind of referred to this earlier, and it's related certainly to number 8. But if I have a point of contact with a patient, I would always try and ask, hey, how is that going? Are you attending some of those self-help groups we talked about? And then they might say yes, and I'd say great, or I might even say, hey, I saw you. It's good to see you on Friday night when you came into the men's AA group. That's a great way to see if they were able to engage in some of those referral services. But number 8, really, but going back to number 8, this is really considered a best practice courtesy. It's not a requirement oftentimes for licensure or anything, but it may be encouraged, and it really falls within that best practice. Your patient's health and well-being may very well rely on it, and if you have ROIs in place, try and make that call. I used to designate a couple hours a week to just do follow-up calls, follow up with folks, see how they're doing, or a letter. And 9, following up with the patient is also very important and may provide an opportunity to further ensure that they're getting the care that they need. I know some of this is pretty straightforward, but I think it's important to acknowledge this. And those of you that are new to the field, this is good stuff. This is stuff that I really needed to hear and learn about and understand as I was entering the field and starting to work with patients that needed my support. Let's talk a little bit, but let's shift gears now. I want to talk about service coordination, and this is a quote that came from one of my colleagues here on our Native Advisory Council, and I thought this was interesting. Since the beginning, Native people lived a life of being in harmony with all that surrounds us. It is a belief that all humankind are related to each other. We believe we are related to all other living species, the winged ones, the four-legged, the plant life, and the elements of life, air, fire, and water. The sun, moon, stars are there to guide us. And this came from an Ojibwe and founder of AIM. And I really thought that was the reason that we wanted to include that is because it's the service coordination is the same idea that everything is connected, especially if you're in a smaller or medium-sized community. There may be many people that you've had lifelong relationships with that are also you're working with professionally or paraprofessionally. So I really thought that was an interesting quote to include in this idea. From a sort of clinical or Western approach, service coordination is seen as the administrative, clinical, and evaluative activities that bring the patient treatment services, community agencies, and other resources together to focus on these issues and concerns identified in the patient's healing plan. And this healing plan has been developed, remember, in collaboration with and really driven by what the patient is interested in doing, what they want to work on. But that's sort of a kind of a quick nutshell, kind of dry version of what service coordination involves. So let's build on that a little bit. Yeah, Andrea's making a comment here. That I agree, Andrea. Each client's healing journey is unique to them. Yeah, I agree. I agree, and it's really, I'm encouraged because the shift and the trend, the best practice trend, is to really let the patient be the driving factor behind what they want to work on or not want to work on, and reminding them that really it's up to them. And sometimes that can be a challenge if they're referred through a third party or they're on their, third, second chance with their PO and they're, down to their last straw. It can be a real challenge to say you do have a choice. Sometimes they don't. But yeah, I agree. Mandating a particular way of recovery is really a disservice because we know there are many pathways, as Andrea noted, to getting better and recovering. And you guys have heard me say this before, a patient's substance use is not the problem. A patient's substance use is not the problem. It's causing them problems. Don't get me wrong. It's definitely having an impact, but it's really a symptom. It's an indicator that there are other underlying issues going on with them. And this was really important for me to understand early on, because people use alcohol and drugs because it makes them feel better initially, and it may help them forget or mask some other things going on. But the challenge is really to start to address and explore alternatives to addressing those underlying issues. If I saw 10 patients in a day, I would say 9 of those would report to me some kind of grief or loss or trauma in their lives, either recent past or distant past or current. And that really would be the area that we might focus on as we build rapport and trust one another and work towards solutions. So I hope that makes sense to everybody. It's been a really important part of my own clinical work in trying to connect with patients and meet them where they're at. So let's talk more about service coordination. This idea of a multidisciplinary team, I think, is really becoming more commonplace. It's really more the norm now than the exception. We still get into our silos. We still get, stuck in our silos. Well, I only focus on substance use disorders, or I only focus on mental health, or I only do medical, or I only do dental, or I only work with families. But I think there's an idea of pulling the team together and having expertise in areas that this team then, becomes, its sum becomes, greater than its parts. It becomes more, this multidisciplinary team, but it really helps, I think, the patient also make sure that they're receiving and having all different angles considered. And it can really be a combination of a number of different professionals. I know a big part of our multidisciplinary team in our clinic was, having a nurse on duty, and having a registered nurse or a physician's assistant and our medical director. She was absolutely vital in some cases where I could consult with her on a specific medical condition or a specific psychiatric condition. And that was absolutely essential to the multidisciplinary team approach. So it can be substance use disorder counselors, mental health, physicians, psychiatrists, registered nurses, pharmacists, case coordinators, attorneys. I mean, it can be, I can't tell you how many times the part of that multidisciplinary team might actually be a probation officer or parole officer, where they would have a specific role. And of course, a peer recovery support specialist. What a great sort of component to any multidisciplinary team. It's absolutely essential. It's best practice. So service and coordination includes things like case management and patient advocacy. And by that, I'm talking about, being able to, when you're making a referral or connecting or coordinating or trying to collaborate with other agencies, being able to really advocate for that patient in a positive and genuine way, to let that other service or other entity know, where the patient is at and what's going on and where their strengths are and where they still need some support and work. It really provides this framework of action for the patient to move forward in their recovery. And most patients, my experience has been, they're not going to achieve maybe all of their goals, or there may be some goals that are lifelong or extended long-term goals, but it really provides a sort of a pathway to achieving specific goals, especially the shorter term goals that may be directly related to their early recovery. The collaboration between the patient and all members of his or her disciplinary team is really designed to provide the most effective treatment to the patient and their family. So service coordination is really, in and of itself, I think, a real art form. And once you've established connections with services in your community, it really can be an amazing process. Again, just to build on this idea of service coordination, it involves collaboration with the patient, their significant others, could be coworkers, it could be peers, family, or this this TIASPE idea. We know that family has a different meaning or a different construct, the nuclear family versus an indigenous view of family, which is much broader and much more, interrelated and much larger version or concept of what family is. But this idea of engaging all of these resources, these supports around the patient, and there may be times, honestly, where it's in the best interest of the patient not to have them engage with their family members, at least not initially. And I know that might be, it might not be easy to understand, but there are sometimes levels of dysfunction and toxicity within the family system that to put the patient within that system can be really detrimental to them. So, but we still want to consider who is connected to the patient, who are their supports. Family can mean a lot of different things. I have an AA family. I consider them like family. They're different from my biological family. But also coordination of treatment services and referral services, acting as a go-between, having some go-between sort of activities to connect them to community resources. So it could be a peer recovery specialist, taking the patient to their first self-help group, and then from there they network with others in recovery. Acting as a go-between between the managed care systems, going and engaging in mental health services in a hospital setting can be tricky. Ongoing evaluation of treatment progress, even post-primary care, and ongoing evaluation of what the patient's needs are. Let's see, we got a couple of comments here. Oh yes, that's a big chat, Paul. Yeah, I agree. Yeah. Yes. Yeah. Yeah. I agree completely with your comment. It can be tricky to navigate, and yeah, it can be like going upstream a lot of times. I agree. I completely agree. Again, let's talk a little bit about one more slide about service coordination, and then, or I guess this is the slide where I want to transition to service coordination and involving that treatment plan, that living document that you had and been developing with your patient. So it can be sort of the stepping stone to collaborating with a referral source. It can, that treatment plan can help obtain, review, and interpret all of that information that you've gathered up to that point. Absolutely essential. It's going to help act as a guide to connecting them with services beyond their primary care. It can oftentimes serve as that bridge between the patient's eligibility, clinically or diagnostically, as well as their readiness. So that's really twofold. If a patient is in a still or remains in a pre-contemplative stage of change, they may not be open or receptive to, continuing care services or engaging in other services. And I have to be realistic about that and understand that may be, I can still make the referral, but I can't vest all of my worth as a clinician in whether or not the patient follows through. I have to be willing to accept that maybe they're not ready for that, but you've made the referral, and when they are ready, they're going to know sort of what path to take if they want to pursue that. And, again, it also, including implementing the treatment plan into service coordination, can really act and serve as a necessary administrative procedure for admission into another service. So it might be, it might serve as a stepping stone to making referral to a higher level of care or to a peripheral service not related to substance use disorder. So again, just this idea of using the treatment plan, implementing the treatment plan, it really, it helps establish accurate treatment and recovery expectations with the patient and those that they are going to be living with and spending most of their lives with. It really acts as a guideline for those that are trying to help be part of the solution with the patient. Yeah, Gene, I understand. Yeah, I agree. Yeah, that's so true. I mean, I think some of the toughest cases and patients that I had were especially youth or young adults. The youth that were still living at home and coming to a session and telling me that they were around their parents or siblings that were actively using, and that's where there were a handful of cases where we looked at emancipating them and what that would involve and getting them into an independent living situation. But it can be really, really difficult to sometimes to put them back into that same environment that they've just come from. Yes, Gail. We in the follow-up email, we will send out a PDF version of this PowerPoint, and I would just encourage all of you that if you would like to use this in a good way to help others, just make sure that you denote the source that it came from, the American Indian Alaska Native HTC, and maybe throw SAMHSA in there too, as I mentioned, just so we can keep our funders happy. But anyway, yes, we will make sure we get these slides out to everyone. How are we doing on time, Parker? Okay, we're good. We're okay. Like I said, this is not a huge slide deck, but I want to keep moving here so I don't lose you guys. I really appreciate everybody being on, and feel free to put more comments in the chat. So again, I want to build on this idea of implementing the treatment plan into this service coordination. This idea of having this kind of referral list, this community referral list, whatever mechanism you want to use, whether it's an Excel spreadsheet or a Word doc, or having it built into your electronic health record system as a drop down or something. There can be a lot of ways to maintain an active, accurate referral list. I'm sure some of you have ways that you're doing that already with your agency. Having this ability to collaborate with different professions within the community, whether it's the recovery community themselves, or whether it's with a specific therapist, maybe doing EMDR or DBT, or someone that you like your go-to for a patient that would really benefit from a specific kind of therapy. Or it could be something as important from a cultural standpoint. It may be having an ability to make a referral and connect them with a spiritual leader in the community that could engage them in ceremony, and they could get into sweat lodge or do something that will be part of their recovery if they're receptive to that and it's appropriate. Delivering case presentations. So again, this could be part of a referral or a coordination of services where you're trying to give an overview of the patient's history to help who you're coordinating with better understand the needs. And then just using, it says appropriate technology, but I would think just, current technology, especially now with so much of our record keeping being done paperless, it can be a challenge to utilize that kind of technology, in a good way. But those are some other things to keep in mind. Just a few other things, obviously, you want to have clear verbal and written communication. You want to try and have this team building within your interdisciplinary team. And there's going to be times where there's negotiation and advocacy. How many of you have been on the phone trying to advocate for a referral for your patient through an insurance coverage or through an agency that maybe is saying they're not appropriate for our agency, and you really have evidence that says otherwise? Sometimes you can really be the greatest advocate for the patient, especially if they're on board and supporting what you're trying to do with them and for them. Again, assisting a patient in developing and maintaining that connection, whether it be through any of those means, but maintaining that connection with them, and as it relates to their treatment plan and goals and plans that they're working on, and of course to document this advocacy, this outreach, these referrals. Really important if you need to go back or someone else is reviewing the case if you're not available or are not with the agency anymore. Service coordination includes consulting, and I think consulting is sometimes underutilized, but it can really be an important piece. I can consult with a colleague outside of my agency about a patient without a release. I just can't share any identifying information. But I could go and talk to a colleague in general and consult with a psychiatrist. I had a couple friends, colleagues and friends in the recovery community that were also professionals in the community, and I sometimes would consult with them about a patient without revealing the patient's personal information or identity. But summarizing the patient's personal and cultural background, treatment plan, recovery progress, and problems inhibiting or some of those challenges or roadblocks to progress. I could ask, have you ever had a patient that had X, Y, and Z going on, and how did you address that? Consulting is sometimes underutilized, but it's really important to keep that in mind when we're talking about service coordination. It can be part of that multidisciplinary team contribution, and of course, we need to apply confidentiality regulations. There may be times where I'm consulting and I have to have that release in place because I need to share specific information. So we have to be mindful of this as we consult or compare notes with our colleagues and other professionals outside of the agency. Service coordination includes continuing assessment and treatment planning. Well, we've talked about this all along. That treatment plan begins the day they do their assessment, and it may end if they don't follow up or there's no further services needed, or it may continue all the way through to discharge and beyond. But maintaining ongoing contact with the patient, again, logistically, that can be a challenge, but I know I had a system where before I closed a patient out, wrapping up their case, I would give them a call and just check in with them. It didn't always work, and it wasn't something I could do with every patient, but something I tried to do on a regular basis. Understand and recognize stages of change and other signs of treatment progress. Well, we know the stages of change. If you're not utilizing those, it's not something that all agencies are using, but this idea that we meet the patient where they're at. Those of you that are familiar with the stages of change would understand this, and you adjust your approach depending on their readiness to change. Excuse me. Make appropriate changes to the treatment plan to ensure progress towards treatment goals. And that's sort of related to that previous bullet point. And then, of course, describe and utilize documentation procedures to monitor progress and outcomes. There's just, this idea, if you have not heard of the stages of change, this is just sort of a visual on this. Pre-contemplation, remember in the old days, what did we used to call pre-contemplation? The orange block. What did we call that? Doug, you remember what we used to call this? We used to call this what? It's a river in Egypt. What did we used to call somebody in a pre-contemplative stage? Anybody? Somebody unmute and tell me what is there? Some old school counselor out there.
Was that denial?
It was
Denial.
denial. It was the river in Egypt. That's right. And that, denial sort of puts that patient on their back foot. And it's a term we just don't use much anymore, at least in the best practice model. But I think it looks like some people have chimed in here on the chat too. Yes, you guys know. I've got some old school counselors out there, so it's good to know there's still some old timers out there. But yeah, so pre-contemplation. If I have a patient in pre-contemplation, that treatment plan and that service coordination is going to look very different than someone in an action stage of change or in a maintenance stage of change. I hope that makes sense, but you can see I don't want to go through all those bullet points just for time, but again, stages of change will influence and impact how we assess and how we place and work with patients throughout their stay with us. It's a great guide to helping the clinician adjust their approach rather than trying to put the square peg in the round hole. I'm going to adjust how I approach. So for example, someone in a pre-contemplative stage of change, I may open a session with something like, tell me what it is that you like about marijuana. I can see here in your chart, I've looked it over through your evaluation, you're smoking cannabis every day. Tell me what you like about it. Now again, I've just taken myself out of the role as I'm going to make you quit. I'm going to make you do something. And I'm just asking them what they value about that particular drug. What a great way clinically for me to sort of take myself out of the role of I'm going to make you do something and try and convince you that you're in denial and that you're a drug addict. Those terms and that approach just really don't have a place anymore in best practice. I know that might be controversial for some, but it's something to keep in mind. Let's shift here. The remainder of the slides, I want to focus a little bit on documentation and the little time that we have. We've got just under a half an hour. I know documentation can sometimes be intimidating, especially early on in your clinical training and orientation. And what I can say is, if it is, that you're right where you're supposed to be. It can be daunting in many ways. Now with a lot of electronic health record systems, your progress notes are time-stamped. You have small windows to get these progress notes or these case notes or group notes completed. There may be pressures on you to do this. There's ways and strategies that you can utilize to make your documentation process more fluid, more meaningful, and more manageable. So there's a lot of choices, and I know there's a lot of different systems for documentation, but it's really important we understand and embrace the documentation process. It benefits you, it covers you, it also benefits the patient and helps you connect with them and be consistent with your work with them. There is a Pakistani journalist and activist, Sohail Sanghi. He said, if it's not documented, it didn't happen. And I know there's probably others that have said this, but that always stuck with me. And my first clinical supervisor, I remember, she said to me, Steve, write your documentation as if someone else is going to be reading this that knows nothing about the patient. Now, that doesn't mean I write a small novella, for every note, but I want to write something that's concise and summates what's happened, so that if they knew nothing about the patient, they'd have a really good snapshot and idea of what's going on. So that was always sort of my approach to that. If I knew nothing about the patient, could I open up and read your progress note or your case note or your group note and understand what had happened in that session, or a little bit about the patient to help me understand?
Steve,
Yes.
what, which do you want, do you use the most? Do you use a narrative or do you use SOAP? What do you use?
Yeah, that's a great question, and I don't want to promote one specific way. I was trained using the narrative form, the NAPT, it
Me
was
too.
narrative assessment plan and time. Really, it can vary. There are some agencies where you're required to use a specific format. If we had a little more time, I might reference it on these slides, but collaborative documentation is another strategy to get your note done with the patient's input at the end of the session. And it takes a little doing. I'm not the best typer in the world, so it was always a challenge for me to type and listen and try and comment at the same time. But yeah, NAPT was the format that I used. I know there are other formats that can be used. There's DAP and SOAP and some other. Yeah, DAP. Yeah, Cheryl says she likes DAP. And really, sometimes it can be system driven. So it depends on what your EHR has, woven into their system. But I think the key is to find something that works for you, no matter what the format is. Find something that works for you, and then also having a working understanding, and understand that there's a reason for this. And I used to say to my clinicians that I was training early on, less is sometimes more. So if I can write a short note, I had one clinician, she was old school, and she sometimes would write massive progress notes, and they were very, very informative, but she was spending way too much time on each note. So it's finding that sweet spot, finding something that works for you and something that interfaces well with your agency expectations, and also serves your patients well, in this at the same time. It's going to help you review your notes when you meet with them. I used to review the note that I had previously with the patient so that I didn't get them mixed up with somebody else, or if there was an issue going on that I needed to circle back to, that note to myself sometimes would help me have some consistency and some some continuity to the work that I was doing. But again, here we see these examples of what documentation can be, and documentation really starts from the moment that patient engages with services, whether it's a self-assessment screening tool, all the way through to a discharge summary or a follow-up phone call. Really important aspects of documentation. They're woven throughout our profession. Documentation is just the idea of demonstrating the knowledge of accepted principles of patient record management. Again, this ties in a lot of times with your licensure and your ability to be reimbursed. If the progress note isn't there, the session, this looks like the session never happened. How do you bill for that? So there can be some real, challenges there. But also to be objective in your documentation. And that's where I think, as Eileen said, having a format you can use, that was real reassuring to me early in my clinical experience, to have sort of a format to follow, so that I wasn't just sort of writing off the top of my head, having a format and a sort of ritual I could go through to write my notes. Regarding patients' rights to privacy and confidentiality, there's a really important piece to this too, on how those records are handled, especially how it relates to how you're sharing these notes to third parties or individuals who are requesting information. only providing a referral source with information they need, not the whole chart or not information that's just not relevant or applicable to that referral source. And making sure that your documentation complies with state and federal confidentiality laws and regulations. And that's where those, releases of information are also a form of documentation. If I don't have a release in the chart and I have evidence of communicating with a referral source or significant other or employer without a release, I've left myself open to, potential legal problems or disciplinary action within my agency. Again, I mentioned this earlier, but having accurate and timely and summarized reports, it takes a little practice. I wasn't that good at it initially, but I had good mentors and good examples of how to write notes, and you get better at them. I know some agencies use templates where you can kind of fill in, check some boxes, and write brief statements, short answers in some of these notes. But it's important to have them be comprehensive and accurate, and that's part of the responsibility for documenting in the right way. Number 4, record treatment and continuing care plans that are consistent with agency standards. Again, there are certain regulations. We know that a treatment plan must be developed in a certain time frame. There must be evidence that there's collaboration between the patient and the clinician, and your documentation will serve to show and evidence that. So absolutely important. And again, documentation has this documentation we're talking about, as I mentioned before we started, this is a very linear sort of Western approach to documenting your services. And it can be sometimes a challenge to adjust your thought process to this and to still meet the patient, work with the patient, and not have your documentation be the most important thing. If I have a patient in crisis, I can set aside my evaluation or my agenda for that session, and I'm just with them in the moment. And I can process and document this post-session. But in that moment, I need to be with them. And documentation is put on hold for a moment. I may ask for assistance from a colleague or a nurse. I had a patient go into seizures. I had a patient that reported taking a large amount of medication before they came into the session. We stopped the evaluation and got an ambulance over and got them hospitalized. There are times, and then I documented that, post-session. But really important to make sure that you are documenting progress towards treatment goals and follow through and things of this nature. That's part of your responsibility, and it covers you and serves the patient at the same time. Again, related to that, just record progress of the patient in relation to treatment goals and objectives. Again, this is the way for you to evidence and show the referral source or even the patient's family evidence, or their probation officer evidence that they're making progress. I used to say to patients, let's show your PO the work that you've been doing, and we could share with them some of the goals and some of the action steps, and had to have that documented and available if the PO requested that, with the patient's consent, of course, making that available and say, here's the treatment plan that we've been working on. Here are the dates it was reviewed. Here are the goals that we're working on. Here are the goals that we still need to address. Here's the ones that we've achieved. What a great way to advocate and to demonstrate and evidence the work that patient's doing. And again, discharge summaries, these can pile up, if you don't watch it, these can really pile up. So we had we had, a goal of having that discharge summary completed within 30 days of the patient's last date of service. That was sort of an agency standard, and it really helped in our electronic health record system. You would get a little reminder 7 days before that date. Patient's discharge summary is due in 7 days. There's that kind of technology that sometimes can be, a real pain in the neck, and other times it saved me, where I would be like, okay, I've got to get this discharge summary completed. But discharge summaries can be important for referrals. They can be important for service coordination and step down in or transfer. We used to do transfer summaries as well. So if a patient was going from one level of care to the other, we would do a transfer summary so that the clinician in getting that referral internally would have a nice summation of their status and work that they did at that higher level of care. Hope that makes sense. Documentation or document treatment outcome using accepted methods and instruments. And again, we fall back and look at our agency's policies and procedures. What are the expectations from your state and from your funders? But really using different ways to measure. And this can be something as simple as, having lab results that indicate that the patient is no longer actively using substances. Urine screens were absolutely a vital piece of our documentation. It was one of the greatest means to show and build trust for the patient, to build trust with those around them. And very easy to make something like that punitive, but I really reframed those drug monitoring mechanisms as absolutely essential. And it was the greatest way for the patient to show those around them that they were really doing what they say they were doing. And having collected gallons of urine in my career, I can assure you that urine screens are, if they're not part of your treatment milieu, then you really should talk to your supervisor about making it so. If you're working outpatient services and not collecting urine screens, we don't have time. I need to stay on track here, but I hope that if you're working outpatient services in this field, that you are doing breathalyzers and urine screens or saliva tests or some way, because otherwise you're doing a disservice to your patient. That's all I'll say about that. I don't want to get going too far on that. Just a few more slides. I want to look at community case management. And again, case management for many agencies is a luxury. And, our case managers usually ebbed and flowed depending on our funding. Sometimes we had funding for case managers or special projects or research projects, and other times we didn't have case managers. So the clinician had to kind of fill in as the case manager. But I want to look at this from a strengths perspective. This idea of case management, and we know this can be, real boots on the ground stuff, driving patients to appointments and helping them connect with services and resources around the community. But it really looks and tries to encourage the patients to become more deeply involved in their own treatment experience. And it assists the patients in learning how to acquire and retain resources that will support their recovery. So it really is saying, what is the patient good at? How can we interface them with resources in the community that will enhance those strengths? But this was really a really important concept, and this was looked at and studied and researched quite a bit in the early 2000s. There are really 5 principles for the case manager: facilitate the patient's strengths and abilities and assets, and to assist the patient in focusing goals, identifying alternatives, and locating resources by encouraging them to identify their own needs. So again, very, very much patient-centered and patient-driven, which is, you know, a little bit different from sort of my instinct is to, you know, and sometimes patients will say, tell me what to do, you know, tell me the answer, what's the solution? And my instinct is to give them that, you know, to want to fix it, to want to jump right to the solution. And it's really important for us to sometimes to let that patient explore that themselves. So again, it serves as a primary advocate for the patient and coordinates all relevant services. It really is believed that it encourages positive and proactive identification of the resources that the patient has available, including those community supports and agencies. And it can be, you know, within that diospe, within that family, or within their group of peers, or within the community itself. And the works with the patient in the community to maximize the fidelity of the provider's perceptions and the patient's experiences. So it's important to consider that strengths perspective when we're talking about acting as a go-between. I know we used to we had a program called Bridging the Gap, and it was a representative from the AA community that would come in and talk to our residential patients about how AA has worked in the past. And it didn't mandate anyone to go to AA, but it at least gave them an opportunity to make a connection. And if they were interested, they could follow up with that representative. Let's just briefly look at these last few slides. I wanted to just share a couple of research points with you. Some of the case management research involves comparing research results from across case management oriented programs. This is difficult because of the way you know, case management, the concept of what case management is varies. It isn't a set definition. There really is an indication that there needs to be more study about what role case management can play and to what degree it can impact the agency's influences on reduction of recidivism and keeping patients connected and on their recovery path. I know having case managers can be a real luxury for many agencies, and I don't know if you guys have case management built into your programs, but I know peer recovery specialists are fulfilling some of those roles now, as opposed to an identified or designated case manager. Just wanted to share, these are just some different resources. Again, we'll make this slide deck available to all of you post presentation today. We'll send out a PDF so you can check some of those resources out. I did include our center's main website. It's a little clunky to get around, but once you get in there, it's pretty easy to find stuff. If you have any questions about that, you can always reach out to me as well, and I'm happy to answer any questions you have. That's just a kind of just a summary of what we went over today. And there's my contact information. Let's see, look at that. 5 minutes to spare, ladies and gentlemen. There's hope for me yet. Maybe 2023 is really going to be, maybe this is going to be my year. I don't know. We've got a few minutes. I would be happy to take some questions. I don't know if Parker's still on or not, but if you get a chance, I think he posted that survey link. If you can't get that done today, don't worry. We'll give you another opportunity when we reach out to you via email. But couple of minutes for questions. Anybody have any thoughts or ideas or anything they want to share?
I'd like to say sometimes there's more than one way to do things. and there's always room for innovation and change.
Yes.
And for some things, there's not.
Yes. I am just going to agree with you on that, Cheryl. I think that is probably a philosophy that applies to quite a bit of the work that we do. Anybody have anybody behind on their progress notes? Oh,
Don't everybody raise your hand at
yeah,
once.
that's right. That's right. If you are, it's okay. You can catch up. But yeah, I really appreciated having you guys on. We've got a couple more minutes. Oh yeah, for sure. Tony, I'll put that in there.
Steve?
Yes.
Hi, Mabel.
Hi, Mabel.
Wanted to just say from my experience, I worked on an inpatient psychiatric unit
Mhm.
when we had patients that had substance abuse as a diagnosis as well.
Yep.
And we were in the process of doing discharge planning way ahead. I'm thankful that part of your presentation had to do with treatment planning, starting from the beginning when we do our assessment and evaluation, all the way to when they're actually getting ready to leave the treatment place. And so I would actually escort a patient to the intensive outpatient program
Yes.
that would involve both substance abuse and mental health services.
Yep.
And I would sit in the waiting area and have them sit in different kinds of meetings. Like they
Yep.
had the AA meetings that were for co-occurring disorders, or they had an NA meeting,
Yes.
and let them have the experience to say, this is something that I accept or not accept, and then talk about it when we would go back, so that way the transition to the aftercare program was something that they would buy into rather than it be forced on them.
Yes, that's a great point, Mabel, and we would call that a warm handoff or a warm handoff referral. And if you have services under one roof, it could be just a really seamless best practice a routine, and likelihood of the patient following through or seeing the purpose or meaning behind that is increased quite a bit. So thank you for sharing that.
Mhm.
Yes, soft handoff. Well, we're nearing the bottom of the hour. Again, just maybe one more question or comment before we wrap it up.
It feels like it's got sand in it. Just soak them with the hot dogs. So, one of the things that to me would be helpful would be to get one of our intake methods and show her, what we do, so that she could look, kind of.
I'm not sure if Eileen, are you? Eileen, it says you're muted, but not sure if she's asking us a question or. Eileen, your mic is open, so wasn't sure if you were asking.
Sorry.
That's okay. It says you're muted, but I can still hear you. We can all hear you.
Okay.
I thought maybe you were asking a question to the group.
I'm talking to my boss.
Okay, well, yeah, it just says you're muted, but we can still hear you. So there we go. Okay, well, folks, I want to just, again, I want to thank everyone for joining us, and it's been great to see some familiar names and faces. Please reach out if you have any questions, and we will see you again next month, first Wednesday, for our next ESAS installment. I think I will have a guest lecturer coming in, but who knows? You might end up seeing me again at some point. We've got some other events going on in the coming days. And we'd love to have you join our virtual native talking circle on Monday. Many of you attend that are in the group now. So great to see everybody. Thank you so much. Until next time, stay safe, stay healthy, and most importantly, stay connected. Bye.